Hi, my name is George Verdejo, and I'll be discussing the use of duplex ultrasound for evaluation of patients prior to various endovascular and open arterial procedures. Our objectives today will be to discuss the history, rationale, and protocol for use of duplex scan assessment of patients with suspected peripheral arterial occlusive disease, to describe techniques for imaging of the lower extremity arteries, to identify common pitfalls of lower extremity arterial imaging, to provide tips and pearls for facilitating the examination and overcoming those pitfalls, and then we'll review a few representative cases. As you know, contrast arteriography has long been the gold standard for evaluation and imaging of the lower extremity arteries. Interventionalists and vascular surgeons have a long experience with this technique, and they've reached a certain comfort level with the images that are required. These images are easily interpreted and provide lots of detailed information, and also serve as a great surgical guide for the performance of lower extremity bypass grafts. Arterial duplex scanning, on the other hand, has traditionally been used only to confirm the presence of suspected peripheral arterial occlusive disease, or to confirm the presence of a lesion seen on some other imaging study. It was sometimes used to define the anatomic location or of stenotic or occlusive lesions suspected by other indirect testing methods. But traditionally, arteriography was used prior to all interventions, and duplex was really rarely integrated into the decision-making process. However, there are various reasons why one might move away from the more invasive contrast arteriogram, and I've listed here a few of those issues, all of which point to duplex ultrasound as a viable alternative for imaging the lower extremity arteries. The rationale for supposing that duplex ultrasound could be used in this setting is based really on two genres of studies in the literature. The first that evaluated the ability of duplex ultrasound to image the lower extremity arteries. In this study from Dr. Mineta, published in the Journal of Vascular Surgery of 1992, his team sought to assess the accuracy of duplex ultrasound to evaluate individual arteries and to detect greater than 50% stenosis and/or occlusion. They looked at 150 patients in whom they compared the duplex ultrasound to the contrast arteriogram results. Their results were very good. They showed 99% visualization at and above the knee, and a sensitivity for documenting greater than 50% stenosis that ranged from 89% at the iliac level to 67% in the popliteal artery. These results were equally as good in the arteries below the knee. Keep in mind that these results were obtained with technology that dates back to 1992, and with the exquisite imaging and technology that we have today, imaging of the lower extremity arteries has much more improved. This study from the University of Washington looked at 110 patients in whom they identified 50 lesions that they thought were amenable to percutaneous transluminal angioplasty based on the duplex scan results. In 47 of 50 of those lesions, or 94%, the patients in fact went on to get a percutaneous transluminal angioplasty. There were 3 cases where PTA was not performed because the procedure was thought to be technically difficult. The take-home message in this study, however, is that there were no percutaneous transluminal angioplasties done in patients found not to be suitable by the duplex scan. In other words, the results of the duplex scan did not exclude any patients from receiving treatment. Based on those studies, the landscape really was changed for us in the vascular laboratory, and the role of the duplex scan evolved really to pre-intervention imaging and/or mapping to determine whether or not a patient is a candidate for an endovascular versus an open approach. The goal was to identify the site of the lesion, to determine stenosis severity as well as the length of the lesion, and also to assess the status of the distal runoff. In these patients, a limited then intraoperative arteriogram can be performed, and then the intervention can be facilitated. In general, the idea was to detect and to localize severe disease and eliminate the need for routine diagnostic arteriography. With the evolution of the technology, we further sought to answer the question, was duplex good enough as a sole imaging modality prior to lower extremity bypass grafting. The group in Brooklyn, Dr. Asher's group, have been huge proponents of this technique in this setting, and they published a paper in 1998 titled Value and Limitations of Duplex Ultrasonography as the Sole Imaging Method of Preoperative Evaluation for Popliteal and Infrapopliteal Bypasses. And our own group, with Dr. Wayne as the lead author, published a paper in the Journal of Vascular Surgery in 1999 asking the same question. I'll very quickly go over the results of our study. We looked at 41 patients who were undergoing arterial reconstruction, all of whom had both duplex ultrasound and arteriography. The observers were blinded to the results of the angiogram and were asked to predict the operation and the anastomoses based on the duplex results. Those predictions were then compared to the actual surgery that was performed. The results are as follows. We were able to predict femoral popliteal versus infrapopliteal bypass in 90% of the patients, and in those patients we were able to predict the anastomotic sites in 90% of the patients. We were able to predict infrapopliteal bypass anastomoses in only 24% of the patients. The primary issue in this case was the inability of the duplex to predict the preferred outflow tibial vessel. We felt that by duplex alone we couldn't really determine which vessel was best for an anastomosis based on the ultrasound image. Using techniques that I'm about to describe, we've been able to create arterial maps such as the one that you see here, and use these maps then to predict the type of intervention that would be most appropriate for the patient in question. This has allowed us to decide, again, what type of intervention is appropriate or even possible. These interventions can range from endarterectomy to bypass, angioplasty, thrombectomy, lysis, and in some cases, conservative therapy when the results of the duplex scan show that really no viable interventional procedure was appropriate, and this has allowed us to avoid arteriography altogether.